Well, welcome to yet another presentation and lecture focusing on sarcopenia and diabetes, the undesirable partnership of advancing age. So let me just give you the outline of the presentation. First, the introduction. Here we will discuss the role of muscle in terms of its mobility and as well as metabolism, especially glucose metabolism. And then what's the definition and how do we diagnose sarcopenia? Then try to elucidate the complex pathophysiology of age-related sarcopenia, discuss the bidirectional relationship between sarcopenia and type 2 DM, as well as the connection between obesity and sarcopenia. And we'll briefly discuss the shared factors and impact of sarcopenia on type 2 DM as well as obesity. And then go to prevention and management, and finally recap, summary, and conclusion. Okay, so as an introduction, what are the different functions of skeletal muscle? Skeletal muscle contraction powered human body movements and are essential to maintain stability. Skeletal muscle tissues account for almost half of the human body mass because of its large surface area, and beyond its primary role in generating power for movement, skeletal muscle is crucial for maintaining glucose metabolism homeostasis, which is the focus of our interest. So, given its central role in human mobility and metabolic function, any deterioration in the contractile, material, and metabolic properties of skeletal muscle has an extremely important effect on human health. Let's delve into the metabolic role of skeletal muscle. A research done by Jurek et al. Demonstrated that 70% of glucose enters the circulation postprandially, with 40% of this glucose being absorbed by skeletal muscle. This study highlights that the majority of the glucose is taken by the muscle following a meal. Therefore, skeletal muscle represent the primary tissue responsible for peripheral insulin sensitivity as well as glucose homeostasis. Another study looking at the effect of insulin on peripheral and splanchnic glucose metabolism in type 2 DM, no less done by Professor DeFronzo. His study was compared with normal individual. The study revealed that muscle tissue was responsible for 90% of glucose uptake of the infused glucose that was disposed or metabolized of by the peripheral tissue in the control subject. These are the reason why skeletal muscle play a major role in glucose homeostasis. So let's now go into the terminology of sarcopenia. Sarcopenia was coined by Erwin Rosenberg in 1989, and it is derived from a Greek word sarx, meaning flesh, and penia, meaning loss, reflecting the condition that is characteristic loss of muscle mass and function. Sarcopenia is currently defined as degenerative loss of skeletal muscle mass, strength, and function with age. It is the major cause of disability and loss of independence in older adults, meaning this condition increases the risk of falls, fractures, and overall frailty, making it a critical focus for geriatric care and public health intervention. Then addressing sarcopenia through intervention like resistance training and nutritional support can help mitigate its impact on the elderly population. So I'm already introducing the basic management of sarcopenia. Now this slide will show as the age-related loss of muscle mass. As we age, we experience a reduction in muscle mass. Muscle mass develop and peak at about 25 years, and after age of 30, we start losing muscle mass and function. This muscle loss is even more pronounced if we remain inactive, leading to a 3 to 8 percent decrease every decade after the age of 30. The decline accelerates around the age of 75 but can start as early as 65 or even as late as 80. At the bottom, both men and women exhibit a similar pattern of age-related muscle mass loss. The difference lies on men generally start with higher baseline muscle mass and strength compared to women. This initial advantage means men may have a greater reserve, potentially delaying the onset of sarcopenia. Now, sarcopenia, loss of muscle, affect everyone as they age, and this comes out very starkly in this slide. If you look at this, these are the CT scan of the mid-thigh of 3 women who are at different ages but have a similar body mass index. At 3 o'clock, you see a 33-year-old woman with her thigh just full of muscle, and white area in the center is the femur, but very little fat. When you go at 7 o'clock, this is a 55-year-old woman, and the dark area and the peripheral is fat, and so the muscle has become smaller, and there are more subcutaneous fat, and also the muscle seems to be infiltrated with more fat. And then finally, healthy 60 or 80-year-old women at 11 o'clock, with much smaller muscle, a lot of fat around the muscle. This document highlights the decline in muscle mass, characteristic of sarcopenia, which begin in virtually everyone starting in their mid-30s. Now, it is possible to maintain muscle mass, and this is a picture of Mr. John Turner, a weightlifter who was on the cover of Gerontologic Journey when he was age 63. And he has quite an impressive physique for a 63-year-old. And they did publish a picture of him 16 years later, and he continued to be an avid weightlifter and still looks amazing for a 79-year-old. But if you look carefully, you can see that even he, despite his active muscle strengthening and muscle building exercises, he has lost muscle mass. Now, this is the Baltimore longitudinal study of aging, abbreviated with BLSA, is the longest running scientific study of human aging in the United States, initiated in 1956 by National Institute of Aging. The BLSA enrolled healthy volunteers aged 20 and older and followed them throughout their lives, even performing autopsy when possible. This longitudinal design allowed researchers to observe the natural aging process and distinguish between changes due to aging and those due to disease. This data examines sarcopenia, the age-related decline in muscle mass and strength, which significantly contributes to frailty and reduced physical function in older adults. Measured here are the knee strength through isokinetic dynamometry and muscle mass determined by DEXA. Interestingly, as you can see, the rate of decline for both parameters is steeper with older age, but the decline in the muscle strength in blue bar is substantially greater than the decline in muscle mass, represented here by the open bar or the white bar. So the BSLA study findings underscore the need for a dual focus on both muscle strength as well as muscle mass in the management of age-related sarcopenia. This is the reason why the current definition of sarcopenia is loss of muscle and loss of muscle strength or function. So when examining a cross-section of a muscle, such as bicep, you will observe multiple muscle bundles or muscle fascicles. Then inside the muscle bundles, there are multiple muscle fibers or muscle fiber cells. And within the muscle fibers are numerous myofibrils, which are the contractile element within the muscle fibers. The thing is that each of these muscle fibers are not all the same. They can differ and has two main types, type 1 and type 2. And type 2 is subdivided into type 2A and type 2X. They are categorized based on the speed at which the fibers contract compared to the other fibers and the method by which they regenerate ATP, which is the energy source of muscle. Another important thing here is the neural factor. Since skeletal muscle is a voluntary muscle, it all depends on the innervation through a motor unit. In age-related sarcopenia, there is a loss of motor neuron innervation of muscle fibers. The important things to remember here is that type 1 is a slow twitch, very much controlling our posture, slow movement, and type 2 is considered a fast twitch for fast movement. In terms of muscle work and exercise, type 1 is more on endurance since it's more fatigue resistant. In other words, type 1 is a fast twitch, are designed or used for endurance like running a marathon. Type 2 muscle fibers is used in a short burst such as lifting weight and sprinting. Now, we are ready to discuss some of the major mechanisms of sarcopenia or the structural changes of skeletal muscle in sarcopenia. First, the size and cross-sectional area of muscle fibers decrease with aging. And interestingly, the percentage and size of type 2 fast twitch muscle fibers are mainly decreased, and these type 2 fibers are mainly responsible for generating high force and power. And the reason for the decrease in size of muscle fibers have been shown to be mediated by reduction in protein synthesis or an increase in protein degradation. This is why many drugs being developed for sarcopenia are designed to enhance muscle protein synthesis. Impaired mitochondrial function has also been suggested to contribute to sarcopenia through production of high level of ROS and DNA damage or reactive oxygen species that leads to damage of DNA. Another key factors of AIDS muscle is a decrease in the number of motor neuron and regenerative capacity of muscle stem cells called the satellite cells, which resides in the peripheral of muscle fibers and can proliferate and fuse with the existing muscle fibers to form a new muscle fibers. Finally, a systemic factor such as inflammatory cytokines or a decrease in anabolic hormones such as testosterone, microvascular changes, and inactivity may contribute to sarcopenia. Now, in young skeletal muscle, type 1 and type 2 muscles fibers are well balanced. However, in older skeletal muscle, three important changes occur. Loss of type 2 muscle fibers, and this is replaced by type 1 fibers. This shift contributes to a decline in physical performance, making it difficult for older individuals to perform activities with the same vigor as they did in their 20s or 30s. Fat infiltration. Older skeletal muscle tend to accumulate excess fat, which infiltrates the muscle tissue, potentially affecting muscle function and metabolism. Moreover, neuromuscular junction changes. The neuromuscular junction begins to detach or unplug, leading to muscle shrinkage and further contributing to a decline in muscle strength and function as you age. Now, type 2 muscle fibers are essential for executing high-intensity quick movements. Their depletion results in a decrease in muscle strength and power, affecting everyday tasks and elevating the risk of falls as well as fractures. Type 2 muscle fibers also play a very important role in glucose metabolism, and their loss can exacerbate insulin resistance and contribute to the development or worsening of type 2 diabetes. Now, there is no consensus among international study group regarding the current definition of sarcopenia, particularly concerning the cutoff values. However, there is a universal agreement on the importance of measuring muscle mass, strength, and function. The most widely used multi-component operational definition since 2010 is the European Working Group on Sarcopenia in Older People. This definition, which was revised in 2019. The Asian Working Group of Sarcopenia definition, derived from also from the European definition, provides criteria tailored for Asian population with different cutoffs supported by Asian Working Group on Sarcopenia. The International Working Group on Sarcopenia definition is pretty similar to European definition, but includes only low muscle mass and physical performance, excluding low strength. Now, sarcopenia has now been formally recognized as a muscle disease in the International Classification Disease, or ICD, which has a code of ICD-10 M62.84. The European Working Group on Sarcopenia in Older People has provided a widely accepted staging system. We have the pre-sarcopenia, sarcopenia, and severe sarcopenia. Pre-sarcopenia are low muscle mass with no impact on strength or physical performance. Sarcopenia means low muscle mass plus low strength or physical performance. If you have all the three criteria, then you have severe sarcopenia. Sarcopenia can also be divided into primary cause or condition and secondary sarcopenia, which is caused by systemic illness. How do we diagnose sarcopenia? The European Working Group on Sarcopenia advises using the FACS pathway for sarcopenia screening and diagnosis. FACS pathway includes F stands for find cases by the use of Sarc-F questionnaire. So, but what is Sarc-F questionnaire? It is a straightforward, quick, and effective tool created to detect individuals at risk for sarcopenia. It functions as a self-administered questionnaire. The component, the questions to be asked, and the scoring criteria are detailed in this slide. A score of 0 to 2 points is assigned for each item, and the total score ranges from 0 to 10, with scores of 4 and above points indicating the risk of sarcopenia. Now, if Sarc-F questionnaire turn out to be positive, then we go to A, which is assess. And what do we assess? We assess muscle strength by grip strength and chair stand tests. And this is an example of a grip strength test by the use of dynamometer, either manual or digital. On your right is the correct position of the test. The individual should sit or stand upright, maintaining a good posture. The arm being tested should be at 90 degrees angle at the elbow and held close to the body. The forearm should be in a neutral position. And a low muscle strength is defined as a grip strength of less than 27 kg for men and less than 16 kg for women. Now, this is a 30-second sit to stand test. The participant should sit upright in the center of the chair with their feet flat on the floor, and arms should be crossed over their chest. They stand fully and return to a seated position as many times as possible within 30 seconds. The tester records the number of proper repetition, and scoring depends on the age and gender, with lower scores potentially signaling reduced strength and a greater fall risk. So during assessment, if low muscle strength is identified, then proceed to C, which is involve confirmation. This requires further diagnostic tests, typically using methods such as DEXA, as well as BIA or bioelectrical impedance analysis to measure muscle mass. And finally, if there is confirmation of low muscle mass, And then we go to severity. The severity of sarcopenia is determined, and this can involve assessing physical performance through gait speed tests, the short physical performance battery, or SPPB in short, or time up and go, which is TAG for short test. This structured approach ensures a comprehensive evaluation from final screening to determining the severity of sarcopenia, facilitating appropriate management and intervention strategies. Well, these are an example of physical performance assessment for severity of sarcopenia. One is the gait speed, measuring the usual gait speed over a short distance. Is a simple and effective way to assess mobility and functional status. The short physical performance battery, SBVP itself is a battery of tests, indicates balance test, a 4-meter walk test, and a chair stand test, providing a comprehensive assessment of lower extremity function. Or you can do the TAG test, or time up and go, rise from chair, walk 3 meters and turn back, walk back, turn back and then sit, and then you can do also 400-meter walk test. Okay, to confirm sarcopenia, at least one physical performance test indicating reduced function is typically required, alongside with evidence of low muscle strength and or low muscle mass. Now, what is the risk factors? There are two, intrinsic and extrinsic risk factors for sarcopenia. The intrinsic factors, this includes age, gender, genetic predisposition leading to muscle degeneration, hormonal fluctuation, chronic illnesses, inflammation that can cause mitochondrial damage and chronic inflammation. While the extrinsic factors, this includes physical inactivity or sedentary lifestyle, obesity, and other factors such as disuse or bed rest due to prolonged inactivity, and catabolic crisis, which triggered by acute and severe physiological stress. Recognizing these risk factors is crucial for creating targeted strategies to prevent or reduce sarcopenia in a vulnerable group. Now, the consequences of sarcopenia can be categorized into two main types. Okay, one is functional consequences on your left. This is may produce reduction of muscle strength and power, decreased mobility, decreased muscle endurance as well, impaired balance and coordination, and as well as loss of independence. For metabolic consequences on your right, foremost is insulin resistance, leading to diabetes, altered metabolism, increased fat mass, contributing to obesity, inflammation, among others. Now, obesity is another form of sarcopenia that can coexist with diabetes, worsening the condition. There is a bidirectional relationship between the two, meaning that each condition can influence and the development and progression of the others. The consequence of excess fat and low muscle mass are reduced mobility and increased health risk. Combining obesity with sarcopenia create a double burden on the body, making it harder to manage weight as well as maintain muscle function, leading to a poorer overall health outcome. Now, CT scans are quite useful for evaluating the distribution of fat in the muscle. Now, unhealthy lifestyle can trigger a vicious cycle involving diabetes, sarcopenia, as well as obesity, leading to various adverse metabolic conditions. Sarcopenia exacerbates this cycle by causing functional impairments such as decreased muscle strength and mobility, which further worsen metabolic dysfunction like insulin resistance and chronic inflammation. This interaction accelerates the decline in both physical performance and metabolic health, highlighting the need for integrated intervention to break this cycle and improve overall well-being. The prevalence of type 2 DM by age group it's well correlated with age-related sarcopenia in diabetes. This is an enhanced study from 2005 to 2000 revealed that approximately 50% of individuals aged 65 and older have either diabetes or pre-diabetes. Additionally, a significant proportion of those aged 60 and above exhibit notably level of sarcopenia. This indicates that as people age, the prevalence of sarcopenia increases alongside the rise in diabetes. Here is additional data illustrating the connection between sarcopenia and diabetes. An epidemiological data from an Italian study on individuals with type 2 DM and without sarcopenia were analyzed with a focus on mean age differences. This study revealed that individuals with both type 2 DM and sarcopenia are generally older compared to those with type 2 DM alone, indicating that age is a significant factor in the development of sarcopenia among type 2 DM patients. Additionally, the study highlights that older age, longer duration of diabetes, poor glycemic control, and presence of comorbidities increases the risk of sarcopenia in type 2 DM patients. So, the prevalence of sarcopenia and diabetes and sarcopenia interact with each other. The general prevalence of sarcopenia is depending on the definition you use. However, it was estimated, or nevertheless, it was estimated to be 10 to 16% of elderly worldwide. Finding from the Asian Working Group of Sarcopenia, or for sarcopenia, indicated the prevalence of 15% among Chinese adults over 60 years old and a Japanese adult aged 65-year-old with type 2 DM. The English longitudinal study of aging, the odds ratio was 2.43 in men with DM, indicating that men with specific risk factors or condition are more likely to develop sarcopenia compared to those without the risk factors. Interestingly, individuals with type 2 DM, despite having smaller muscle mass, exhibited lower muscle performance and strength compared to non-DM patients. Now, how about sarcopenia and increased CV risk? Okay. The data shows the individual with sarcopenia, regardless of diabetes status, face an elevated risk of CVD. For example, the prevalence and prognosis in a study involving around 4,400 older adults, averaging age is 70, average age of 70, 37% were found to have sarcopenia, which was associated with a poorer prognosis. Cardiovascular risk in individuals with sarcopenia were more likely to have a high cardiovascular score of more than 10% according to the American College or American Heart Association guidelines. This is a study looking at the association between sarcopenia and cardiovascular disease among middle-aged and older adults, finding from the China Health and Retirement Longitudinal Study. Patients with sarcopenia assessed using the Asian Working Group Study 2019 criteria were associated with higher CVD risk. CVD risk in terms of hazard ratio for CVD, hazard ratio for heart disease, as well as hazard ratio for strokes. These findings support the ongoing link between sarcopenia and CVD, suggesting that preventing or improving sarcopenia may help reduce CVD incidence and promote healthy aging in middle-aged and older adults. Now, this slide will show you the bidirectional relationship between sarcopenia and type 2 DM. Now, sarcopenia and type 2 DM share this bidirectional relationship where each condition exacerbates the other, just like sarcopenia and obesity. Sarcopenia marked by reduction in muscle mass and function hinders glucose disposal due to diminished muscle mass, leading to insulin resistance and suboptimal glycemic control. Conversely, type 2 DM exacerbates muscle degradation through mechanisms such as chronic hyperglycemia, insulin resistance, elevated free fatty acids, and inflammation, mitochondrial dysfunction, further advancing sarcopenia. This reciprocal relationship creates a vicious cycle where each condition aggravates the other, highlighting the necessity for integrating management strategies to address both muscle health and metabolic control. Moreover, there is a converging risk factors between sarcopenia and diabetes, notably the age of patient, okay, marked with the asterisk here, and other similar risk factors for both sarcopenia as well as diabetes. The simplified term type 2 DM, because of its insulin resistant and other pathophysiologic mechanism, leads to muscle loss, potentially causing sarcopenia. Conversely, sarcopenia, characterized by loss of muscle mass, reduces peripheral glucose disposal, thereby increasing the risk of type 2 DM in older adults. Now let's go now to the mechanism of diabetes and sarcopenia. So what are these mechanisms that will lead to both sarcopenia and diabetes? Number one, muscle deficit may affect metabolic health through altered glucose disposal, as skeletal muscle accounts for approximately 80% of glucose clearance during euglycemia and hyperinsulinemic condition. Therefore, greater quantities of muscle mass increase glucose disposal and potentially delay the onset of type 2 DM. However, once type 2 DM established, this leads to various pathophysiologic manifestations that have bidirectional relationship with component of sarcopenia. And what's the effect of insulin resistant to muscle health? Now, insulin resistant is the hallmark of type 2 DM that results in poor control. There are several studies on insulin resistant that affect muscle health, and they are as follows. The Mr. O's or osteoporotic fractures in men study, where men over 65 without diabetes but in the highest quartile of insulin resistant had twice the odds of losing equal or more than 5% of total lean mass over 5 years. The enhanced study found that gait speed decreased with higher insulin resistant quartiles in non-DM older men, and loss of muscle strength and mass in those with poor glycemic control likely result from increased protein degradation and decreased protein synthesis. Now, the pathophysiologic mechanisms seen in diabetes also affect muscle health, like inflammation, which are markers, or inflammatory markers, are inversely related to the muscle mass and muscle strength, with muscle strength now recognized as the main component of sarcopenia. Reduced oxidative capacity impair macronutrients metabolism and significantly lower physical performance. Another key pathophysiologic mechanism involves advanced glycated end products or AIDS, which are associated with insulin-resistant obesity and aging. Study of 232 Japanese adult men found that higher skin autofluorescence, a measure of accumulated AIDS in tissues, was linked to lower hand grip strength and leg extensor power. Similarly, a study of about 1,900 participants over 60 years old, skin autofluorescence was negatively correlated with grip strength and hip flexion and abduction strength. Now, when type 2 DM patient develop vascular complications, it worsens sarcopenia. Both micro as well as macrovascular complication of diabetes further contribute to muscle damage. Okay, for microvascular complication, nerve damaged nerve cells that innervate the skeletal muscles can impair muscle contraction and strength, leading to atrophy. Diabetic retinopathy can affect vision, which is crucial in for balance, and good balance is essential for locomotion, physical performance, as well as prevention of fall. Diabetic nephropathy or CKD contribute to muscle wasting. The pathophysiologic mechanism may include a lot, such as inflammation, protein loss, decreased vitamin D synthesis, etc. For macrovascular complication, for macrovascular complication, peripheral artery disease or PAD is linked to reduced hip extension knee and hip flexion strength in older adults. The reduced flow or blood flow in PAD patient can cause ischemia, leading to a decreased muscle strength, mass, as well as performance. Additionally, the pain associated with PAD can limit physical activity and exercise and further contribute to poor muscle health outcome. Now, the anti-diabetic medication that we prescribe to our patient have varying effect on muscle mass and performance in individuals with diabetes. Some drugs are protective, some are detrimental, and others have no clear impact. Insulin, GLP-1 receptor agonists or GLP-1RA, and DPP-4 inhibitors are generally protective in green. SU and glinides are generally detrimental in red, and the effect of metformin, SGLT2 inhibitor, and TCDs remain unclear in black. However, the current data is preliminary and most derived from preclinical studies. More research is needed to make robust clinical recommendations. The etiology of sarcopenia is multifaceted, involving a range of overlapping and interdependent factors. Notably, poor nutrition and physical inactivity are particular interest as they are modifiable risk factors. Currently, the primary strategies for preventing and treating sarcopenia focus on exercise and nutritional intervention. Therefore, I will focus on these two aspects. Now, the higher level of physical activity are protective against development of type 2 DM as well as sarcopenia. Supervised aerobic and strength training, particularly resistance training, is the most effective strategy for improving both muscle mass and function. It also promotes muscle strength, size, quality, and metabolic health in older adults with type 2 DM. Combining resistance and aerobic training with diet-induced weight loss may be the most effective approach for enhancing metabolic and musculoskeletal health in obese older adults. While dietary intervention, protein alone may not suffice for optimal muscle health. Combining protein with exercise enhance anabolic effect with vitamin D, improve muscle and bone health. Omega-3 has an anti-inflammatory and with micronutrients may provide comprehensive health support. Now, let us discuss the distinction between age-related sarcopenia and the catabolic crisis model. Whenever someone presents with sarcopenia, they often use a common graph, illustrating a gradual loss of muscle mass per year starting from age 30 or 40. However, this is only useful for describing population level changes but doesn't reflect what clinician and dietitian see with type 2 DM patient daily. For practical intervention, this model isn't very helpful. Instead, the catabolic crisis model is more relevant, where muscle loss occurs gradually with age but is punctuated by short periods, for example, 1 week or less of rapid muscle loss. These crises are often triggered by acute events such as illness, injury, or periods of immobility leading to rapid muscle degradation followed by partial recovery. This catabolic crisis model emphasizes proactive and reactive strategies to manage muscle health in older adults. Now, interesting study called the bed rest study. In early NASA-sponsored study, young, healthy adults were put on bed rest for 28 days to mimic the effect of zero gravity in space. Various measures including muscle biopsies, stable isotopes, and DEXA scan were used to assess body composition. This young participant lost about half a kilogram, approximately 1 pound, of lean mass in a month, which, while significant, was not deemed clinically relevant. To make the findings more applicable, the recent study involved an older cohort around 70 years old who were put on bed rest for 10 days, a duration closer to a typical hospital stay, and the results were alarming. In just 1/3 of the time, this older adult lost 2 or 3 times as much muscle mass as the younger cohort. In the middle, bed rest for 14 days, muscle loss in the middle-aged and older adult with a balanced gender distribution. Surprisingly, healthy middle-aged adult around 50 years old lost muscle mass as quickly as older adult when subjected to bed rest, despite initial having similar muscle strength and mass to younger individual. These are best case scenario and managing a practical healthy individual with no current illness, just bed rest. And the last study also showed that the inpatient, particularly those treated for community-acquired pneumonia, lost up to 15% of their leg muscle mass in just few days of bed rest, demonstrating the severe impact of short-term inactivity. So we go now to nutrition, dietary protein. Now the current recommended dietary allowance, so RDA, for protein in adult is 0.8 grams of protein per kilogram of body weight per day. However, higher intakes may be beneficial for older adults and those with increased protein needs. So, based on totality of evidence, a number of expert working groups have made recommendation for higher protein intake in older adults above the RDA, and this is especially for the preservation of muscle mass and potentially muscle strength. So, from 1 to 1.2 protein grams of protein for healthy adult, it can go up to 1.2 to 1.5 grams protein per kilogram per day in acute or chronic illness, and even up to 2 grams of protein per kilogram per day in severe illness or injury and with malnutrition. Now, dietary protein plays a crucial role in regulating skeletal muscle mass by influencing muscle protein turnover. This slide will explain the concept of dietary protein intake and its dose-response relationship with muscle protein synthesis. Our muscles are constantly undergoing turnover to the processes of muscle protein synthesis and muscle breakdown. The balance between the two processes determines whether muscle mass increases, decreases, or remains stable over time. In aging, there is an impairment in muscle protein synthesis response to anabolic stimuli like exercise and dietary protein. When we consume a meal containing dietary protein, it triggers a temporary rise in the rate of muscle protein synthesis that lasts for a few hours. There is a dose-response relationship between the amount of protein consumed in a meal and a consequent muscle protein synthesis response. To illustrate this, let's look at the graph. For younger individuals shown by the dotted line, as the amount of protein in the meal increases, there is a graded rise in the rate of muscle protein synthesis up to a maximal effective dose above 20 grams per meal. Consuming more than that amount, such as 40 grams, does not further increase muscle protein synthesis. In older individuals or older adults, represented here by a solid line, lower protein doses around 10 to 20 grams per meal results in suppressed rates of muscle protein synthesis. This phenomenon is known as anabolic resistance and is the key mechanism underlying sarcopenic muscle loss. However, older adults can overcome this anabolic resistance by consuming a larger serving of protein in a single meal. So, to match the protein synthesis, muscle protein synthesis level of a younger individual and counteract anabolic resistance, older adult requires 40 grams of protein. Therefore, a protein intake of about 30 to 40 grams per meal is advised, supporting the recommendation that older adult requires more protein than younger individual to preserve muscle mass as they age. Now, combining higher protein intake and resistant exercise can significantly enhance muscle protein synthesis. Resistant exercise synthesizes skeletal muscles to protein, leading to a greater synthesis response when protein is consumed post-exercise compared to without prior exercise. This effect lasts up to 24 hours, enhancing the response to all meals consumed during this period. This resistant exercise plus protein intake in enhancing muscle protein synthesis is called synergy. And the synergy between the two is a powerful strategy for enhancing muscle protein synthesis, promoting muscle growth, and improving overall muscle function. Now, increasing protein intake in older adults can be achieved through protein supplements or protein-rich food. A study showed that older women who consume extra protein-rich food like red meat experience greater gain in strength and lean body mass compared to those who did not. However, older adult needs to consume 30 to 40 grams of protein per meal to maximize muscle protein synthesis, which can be quite challenging due to appetite or swallowing difficulties. Therefore, there is an interest in finding ways to enhance the effectiveness of smaller, more manageable protein doses to stimulate muscle protein synthesis and preserve muscle mass. And that is leucine supplementation. Now, leucine supplementation has been shown to play a significant role in enhancing muscle protein synthesis. Leucine is one of the three branch chain amino acid common in most high-quality protein. Leucine acts as a nutrient signal that triggers muscle anabolism. It stimulates the mTOR pathway, which is crucial for initiating protein synthesis in muscle cells. And in elderly, leucine supplementation has been particularly beneficial in elder individuals who often experience anabolic resistance. The effective dose of leucine supplementation varies, but research suggests that adding 4 to 5 grams of leucine to regular meal can enhance muscle protein synthesis. This is particularly useful when dietary protein intake is low. Now, the next question is that what are the proteins that are rich in leucine? We can get protein-rich leucine in both animal as well as plant protein, as you can see in this graph. Whey protein has the highest essential amino acids, dotted line there, and leucine content is highest concentration in whey. Now, here's a meta-analysis on the effectiveness of leucine on muscle protein synthesis. This is a secondary outcome of the study looking at the lean body mass and leg mass accretion in elderly. The result shows that the muscle protein fraction synthetic rates was after intervention significantly increased in the leucine group compared with the control group. However, there's no difference was found between the group in relation to the lean body mass or leg lean mass, perhaps maybe because of the shorter period of observation in this study. Now, addressing sarcopenia involves managing the transition from low muscle mass to mobility disability. In the initial stages, incorporating exercise and increasing protein intake can help slow the decline in muscle mass and enhance muscle strength and power. This approach aims to prevent the progression to impaired functional performance and mobility disability. Additionally, there may be an opportunity opportunity to introduce novel pharmacologic agent to promote muscle growth. So, briefly, these are the novel pharmacology on sarcopenia. The SARMs, or the selective androgen receptor modulators, selectively activate androgen receptor in the muscle and bone without affect much of the other tissue, make it very attractive in terms of the side effects. Myostatin inhibitor target the protein myostatin, which is the negative regulator of muscle growth. Now, PPAR delta is a nuclear receptor that plays a crucial role in not just regulating lipid metabolism, but also energy homeostasis and, more importantly, muscle fiber type switching. Activation of PPAR delta has been shown to increase oxidative myofibrils that enhance endurance, mimicking the effect of endurance training. The AMPK is an enzyme that acts on energy sensor in cells, regulating energy balance and promoting catabolic pathways that generate ATP. Activation of AMPK can mimic the effect of exercise by enhancing glucose uptake, fatty acid oxidation, as well as mitochondrial biogenesis. These exercise mimetics could offer therapeutic benefit for individuals unable to engage in regular physical activity, potentially managing metabolic disorders and improving health. However, further research is needed to confirm their efficacy and safety in human. Now, current and investigational medications for the treatment of sarcopenia. These are the drugs that are on a different stages of development. So, in summary, we explored the intricate and detrimental relationship between both sarcopenia and type 2 DM as individual age. Sarcopenia, characterized by progressive loss of muscle mass and function, and type 2 DM as a metabolic disorder, often coexist, exacerbating each other, forming what we know as bidirectional relationship. Sarcopenia and type 2 DM share common risk factors such as physical inactivity, poor nutrition, and chronic inflammation. Additionally, the connection between sarcopenia and obesity can further impair muscle function and insulin sensitivity. The clinical implication of this undesirable partnership leads to increase in the risk of frailty, disability, and mortality in affected individuals. So effective prevention and management strategies are very important, such as resistant training, nutritional intervention, as well as optimal glycemic control. In conclusion, it is essential to address both sarcopenia and type 2 DM in older adults to enhance health outcomes and quality of life. Equally important is the emphasis on integrated care approaches to mitigate the impact of this interrelated condition. So, with that, I'd like to thank you for listening.